And well, good afternoon, ladies and gentlemen, and a warm welcome from an overcast and cloudy Cape Town. It's my great pleasure to have Professor Lisa Kaestner with us here this afternoon, and she's going to be speaking about an old topic that we've spoken about many months ago, but that was by Steve Jeffrey. Professor Jeffrey did the talk, and I thought it would be very useful if we could get a urological opinion, and there is no better a urologist that we have available than Professor Lisa Kaestner. I've always said that I value Steve as one of the 10 best urogynecologists in Cape Town, and that, of course, also goes for Dr. Lisa Kaestner. I rate her as one of the 10 best urologists at the Chris Barnard Hospital facility. So, Lisa, it's wonderful to have you. You have been with us before. And just to remind you that we have FIGO in a short while. That's the beginning of October, Steve. I know you are doing a presentation.
Yes, we're looking forward to FIGO now. It's 4 weeks away.
4 weeks away, Steve.
So and are you all ready? Anything else organized?
Yes, now I'm doing a presentation as well. It's all organized. I'm doing the workshops.
Good. Now we're looking forward to
it. One last thing. What is the one last thing? Oh, yes, the sponsorship. The sponsorship this afternoon. Chris, a great big thank you to you. Sponsors this afternoon is by Novo Nordisk. Is that correct, Steve? I mean, Chris?
No, we don't have any sponsors for tonight.
Oh, there you go.
Well, there we go. What a free
the
sponsored by Lisa Kaestner Urology, to be honest.
The Pelvic Floor Foundation of South Africa.
Doesn't Lisa Kaestner Urology?
The check's in the mail. Check's in the mail.
Yeah.
I'll send you a branded mug.
Branded mug.
I've got one of those branded mugs. They're very nice.
They are very good. Lisa, we have an interesting screensaver that looks like is that what is, if you could just tell us
Scotland maybe,
or Vesuvius, Mount Vesuvius. What actually are we?
So this here is a picture of the road leading out of Mersal in Burgundy. So back when I was still getting a cushy state salary sponsored by the South African taxpayer, I could afford to go and do cycling holidays in France. So yes, this is on a cycle tour that we did
very nice.
About 2 years ago.
That's
when wonderful. I was still gainfully employed.
And now you're just employed.
Yes, now I'm just employed. Yes. Okay, so can I start?
Well, just from our side, Lisa, thanks so much for giving this talk tonight. Lisa's a urologist here at Chris Barnard, but has a very keen interest and is also registered as a urogynecologist and also a professor of urology at UCT. But Lisa's got a very broad experience, and on a personal level, we'll collaborate on a lot of very difficult patients. So thanks so much for giving this talk. It's UTIs. I don't think you can ever know enough about UTIs as a gynecologist, urologist. These are the things. These are the patients that often give us the most difficulty. So we're looking forward to this, Lisa. Thanks.
Thank you very much, Lisa. If you could share your slides, please.
I thought I was sharing. Where is your pelvic floor foundation guy?
No, she's sure.
Can you see them? It should say management of urinary tract infections below. Can you see that?
Yeah, we can.
Okay, good. Okay, so I'll go ahead. So this is actually a lecture I gave to the urology registrars who are prepping for exam because they also don't tend to read enough about urinary tract infections. So anyway, usually, let me just see if I can get my flippant slides to move along. Let's see.
No foul language, please, Lisa.
Yes. So I'll try no foul language. So this is me actually. This is often how I feel about urinary tract infections because it really is a bit of a marathon. This is in the Cederberg, and I'd already cycled about 60 kilometers by this stage and had 3 beers at the whistle stop, and you can see I still have to go to the base of that mountain in the distance, and it's a far way, and it's hot, and I'm tired and I'm thirsty. So this is dealing with these patients is quite an energy sapping endeavor, to be honest, because there is no simple solution for many of the patients we see who have recurrent UTIs. But so just looking at some of the things we'll go through quickly. I'm just going to move along. So I think one of the good things that's happened for us is that there used to be quite a complicated classification of UTIs, but I think they've finally seen sense because the European Association of Urology has proposed this new classification, which is basically just localized and systemic UTI, which is very useful because that's how you treat them. Either the patient's got a localized UTI, they get some antibiotics to send them home, or they have a systemic UTI and they're pretty sick, they need admission, and you really do need to keep a very close eye on them so they don't land up in ICU with urosepsis. Obviously, I think it's, probably not that useful going through the symptoms because it's quite obvious. I think most clinicians will easily be able to tell the difference between a localized and a systemic UTI. The one you just have local symptoms, the other one you have all kinds of other fever, chills, temperature, confusion, tachycardia, and general unwellness. Okay, but one thing I think one does have to think about, even if you are looking at a patient that has got a localized UTI, not a systemic UTI, is that you need to look for those patients who are likely to complicate, even if they have a localized UTI. And those are patients that, by virtue of who they are or their medical background, are at a higher risk of developing a complicated or more systemic UTI. Those are the older patients, the immunosuppressed patients, the patients that have anatomical abnormalities like urinary tract obstruction, those who have neuropathic bladders, those who have indwelling catheters, and then the group of patients who, due to their recent history, may be at a higher risk for more resistant infections, are those who've recently been on antibiotics or recently been in a hospital situation, and those that live in a care center, and also those that have incontinence. And then I think one of the large ones that we do sometimes forget of those who've had recent instrumentation, especially those who've had recent prophylaxis. And we actually often see patients who come with recurrent UTIs who've been in hospital for a completely unrelated cause and then are colonized with awful bugs and just get one infection after the next. So just looking at cystitis as a diagnosis, according to the EAU guidelines, to diagnose a cystitis, you need a history which is in keeping with cystitis, and they mustn't have a vaginal discharge. Remember, this was a lecture I gave to urologists, so you don't want to be treating a PID as a cystitis, and they should at least have a dipstick finding that supports the diagnosis of cystitis. You don't need to culture every single patient with a first episode cystitis. However, if you think the patient has got a pyelonephritis, if they've got atypical symptoms, or obviously, as you know, if they're pregnant, you should be culturing them. It's not really in the guidelines, but I'd also say in that group of patients where they come after you've treated them and they have this persistence of symptoms, even though the dipsticks look negative, I would reculture those. Those who've recently been on a course of antibiotics, or those who've recently been in hospital. And obviously also, once a patient becomes a recurrent UTI patient, you should probably be culturing them every single time they present with a new UTI. Okay, just to remind you that, yes, we know what the classic signs of cystitis are, but in the elderly group of patients, they may not have those classic symptoms, and one really does have to interrogate a little bit further as to what symptoms they have when you have a positive dipstick in a patient. So in the older group of patients, they may just be a little bit confused. They may just, their personality may have changed a bit. They may start falling over, have some vague lower abdominal pain, or develop new incontinence. So all things which one really needs to ask about, because the general public often doesn't associate these kind of symptoms with UTIs. And then to look at what antibiotics to use for a simple cystitis. So the European guidelines recommend fosfomycin or nitrofurantoin. And when one looks at the immunopenicillins and the fluoroquinolones, it's actually, there's quite a strong recommendation to not use either of these to treat a simple cystitis. There are some groups where one would use different antibiotics. I suppose it's not relevant to the current audience, but in men, we always consider that they usually don't just have a cystitis. One has to consider that they have a concomitant prostatitis. So we're then in that group allowed to use ciprofloxacin or Bactrim as well, because both are lipophilic and penetrate the prostate well.
Lisa,
yes.
Can I just ask, what did you say about simple cystitis in women? May we use fosfomycin? In other words, Urizone? Did you say we
yes,
may?
So it's actually recommended that the two things that are recommended are fosfomycin and macrodantin as first line. So basically, you shouldn't be using Augmentin or Ciprobay as in a simple cystitis. And there's a few reasons for that. I'll speak to that in the next slide. Just yeah, so it's those are the two things that we should be using is phosphomycin or macrodantin,
Okay.
according
just
to
on
the
a
European
technical-
guidelines.
So on a technical point, Lisa,
Mm,
firstly from a macrodantin point of view,
yes,
you give 100 milligrams 4 times a day, because I remember speaking to Toby Grayling at one point,
yeah,
and he felt that what we have in South Africa, in the UK, they've got an extended release macrodantin. Yeah,
yes,
we don't. So
yes.
do you agree with that sort of regime, or do you have any ideas on that?
Yeah, I mean we usually give anything from twice a day to 4 times a day. And it's, how long is a piece of string? How sick is the person? This all comes into it. But you are correct that what can be used for the ones that we have here, it is actually recommended that you give it 3 to 4 times a day at 100 milligrams. So it is
Okay.
quite a high dose, and patients do struggle to tolerate it because you can get quite nauseous with it. I have a patient that gets recurrent. She's got a peripheral neuropathy, and she swears that it makes that worse when she takes it. So, and also to remember that one does need to give it a little bit longer than other medications. So,
Take it
I
for
think
3 days or
for
5 days?
yeah, so it's probably more 7 to 10 days if you're going to be treating with
Really?
macrodantin. For phosphomycin, for a simple cystitis, you just have to give one. Whereas if the patient is a recurrent UTI, you would probably, or a patient that's more, a higher risk patient in terms of being old and frail, then you would probably consider repeating it after 2 to 3 days.
Okay, so
Not
you don't
every
actually
single
repeat it
session.
routinely after 3 days. I always give it as a 2 dose
No,
once, another 3
no,
days apart.
I mean,
That dose is good enough.
yeah, I mean, so pretty much if you go back to the old classification, if it's a young sexually active woman with no risk factors, no immunosuppression, no anatomical abnormalities, then yes, you can give one. But basically in all the others, you should probably giving at least 2. And if you think about it, each sachet lasts you about 3 days. And if you look at the guidelines treating the more complex UTIs, you want 10 to 14 days. Then you actually need 3 sachets 3 days apart. So to get to 10 days. So for my recurrent UTIs, I usually give them 3 sachets, not 2.
Okay, thank you.
And there are generics available for the sachets,
Yes.
Steve.
Yes.
Yeah,
but-
there are quite a
but
few generics now.
Just one
Yeah,
last
that's
question. You can use phosphomycin in pregnancy. Can you use macrodantin as a question come up in pregnancy? As far as I know, it's okay in the first, this is the
Yeah.
second or the third trimester, but not in the first. But do you have any further information on that, Lisa? Or not?
No,
Not really.
no, I think usually my first choice would be phosphomycin, to be honest.
Okay. Thank you.
Works well. I think just something to mention as well, when it comes to phosphomycin and macrodantin, they are urinary antiseptics. So they need a certain dwell time in the bladder. So they don't work well in patients that have got severe incontinence or that are catheteritis because the dwell time is not long enough. And I've also seen in patients that have got highly resistant organisms that it does not seem to work well in that patient group. So in those patients, I will usually pick something else. The other thing is, when it comes to dose adjustment, in most of the drugs we use to treat UTIs, except obviously the gentamicin and friends, you don't have to dose adjust until your GFR is actually really low. But if you think about macrodantin specifically, if your GFR is less than 30, you don't excrete it very well. So it doesn't actually work that well in that patient group. And obviously, if you don't excrete it well, it accumulates and increases your risk of side effects. So it's not a good drug for a patient with profound renal failure. Yes, then just to talk again about the huge problems we have with rising resistance, even in patients that are that come to us with community-acquired UTIs. We have very high prevalence of these OXA48 carbapenemate producers, and they really are increasingly problematic. And in this group of patients, sometimes you will see that they have a phosphomycin sensitivity, but they often don't work. Even sometimes they will report that they're sensitive to ertapenem, and then actually the patient won't respond and will have to be converted to ceftazidime avibactam. So I think it is quite important that one considers what antibiotics we're using. I think one of, this is the patient I had recently who, you can see it's really quite a sad state of affairs when a urologist basic urologists need to look at these kind of MICs to decide which antibiotic is appropriate. And I mean, even they're looking for all these various mutations now, even VIM. I mean, when I was growing up, VIM was something you threw down a drain, but now we're looking for it in bugs. We really are reaching a point of disaster here in terms of antibiotic resistance.
But
So,
what is VIM? Lisa? Is it the stuff you put in your toilet?
No. It is also it's a mutation which can kind of confer antibiotic resistance in many of these crazy bugs that we now have to deal with on a routine basis, unfortunately. So the OXA48 we know, but there's a whole bunch of this NDM1s and a whole bunch of others that it's quite sad that we actually have reached this point where we've almost running out of antibiotics for these patients. So I think one thing which has crept into the guidelines that was not there before is the use, well, the non-antibiotic approaches have always been there. And the things that we've heard a lot about in the past is things like cranberry and probiotics and D-mannose. But there's now actually quite a high level recommendation for the use of basically plant extracts for both the treatment of acute UTIs in an otherwise well patient, but also for use in patients with recurrent UTIs. And I think one of them that has this top list, some of the top list is Kaestner. And when one looks at hibiscus, that you also find in Uriclear, that's one of the local products that has it. So there is actually some high level evidence for the use of these. I always call them Kreia and Bossis, for use in patients that have recurrent UTI, especially in patients who've been on a lot of antibiotics and actually don't want to use more antibiotics, and when their symptoms aren't too bad and they otherwise are healthy. So just to mention the first line choices we've already spoken about. You can use Bactrim if there's a low prevalence of resistance within E. coli to Bactrim in your population, but obviously one needs to know what the antibiotogram looks like in your drainage population. I think we're using less and less ciprofloxacin due to this concern with tendon rupture, which can actually happen quite long after you've been on the drug. And also the neuropsychiatric side effects of ciprofloxacin. So the other concern is with Augmentin. So I think the reason that Augmentin has kind of fallen down on the guidelines is because of the huge environmental impact and also because of resistance selection. And when one talks about environmental impact, I think a large amount of antibiotic resistance is driven not only by hospital usage, but by industrial usage of antibiotics, for instance, like the dosing of commercial herds. So basically they're giving it to animals that are food animals, and it in that way gets into the kind of human environment and drives resistance. So one of the other things is this pretty picture here. So for those of you who know Cape Town, this is Camps Bay. Beautiful place. I would love to live here, but I don't have the 10 to 20 million it costs to live there. But no matter how fancy it is, you can see that beautiful white beach there, and a few kilometers off you can see this huge sewage plume. So all of the poo from these people get pumped into the ocean. They may be fancy people, but it's still poo. And there's actually recently been a study published, I think, by University of the Western Cape, PhD, looking at levels of commonly urine excreted drugs within filter feeders like mussels along the coastal areas in places along the coast where this kind of sewage kind of management system is used. So although they've been looking at E. coli before, I think a lot more of the things that people are peeing out is kind of contaminating oceans around where we live. And unfortunately, this is really not good for us in general, especially when one looks at the huge problem we have with resistance already. So yeah, if you come to Camps Bay, be careful where you swim. This is another study published in 2024, which I found quite interesting because there's a lot of patients we see who've been treated for a UTI and then return repeatedly to the practice complaining that they have persistent symptoms. And even though you reculture them and you re-dipstick their urine, you don't find anything. So this study actually reported on patients that had these persistent symptoms, and they found that there's an upregulation of nerves within the bladder. So if you think about what happens when you get a bad UTI, as a protective mechanism, you generally would slough the top layer of your bladder lining, and that not only exposes more kind of nerves within the bladder, but also those inflammatory mediators do promote growth and inflammation within those nerves, which may explain why patients have these persistent symptoms, even though you've cleared the infection. And this is in patients just after infection. I'm not talking about patients who have chronic pelvic pain syndrome. These are patients who've not had any of these symptoms before. They have a UTI and they just have these symptoms that don't go away. Okay, something else which I think is important to talk about is this concept of asymptomatic bacteriuria, and it's basically just having bacteria in your urine without symptoms. There is some reasonable kind of evidence that suggests that if you're colonized with bugs, that it can be protective against other organisms. And I always explain it to patients using the squatter analogy. So if you have people living in the house next door to you and they're just normal, hardworking people, the chance of them jumping over your wall to steal your TV is very, very low, because they're like commensals. They live there. They're friendly. Whereas if the house gets occupied by a bunch of really mean criminals, the chance that they're going to come and jump over your wall and steal your TV is much higher. So I think people get quite shocked and appalled when I tell them that no, they're not catching the UTI from the toilet that they used at work or at the restaurant, that they're reinfecting themselves from the bugs living in their colons and in their vaginas. They get quite shocked. So I think it is important to realize that these bugs can be protective. And there's in fact evidence that if you treat asymptomatic bacteriuria in women who have recurrent UTIs, that you in fact it has a deleterious effect, and it can really predispose them to more UTIs instead of helping them. So in patients that are pregnant and in patients where you're going to do a mucosal breaching procedure, it is important to treat those patients with asymptomatic bacteria. So if they've got bugs and no symptoms, but in most other groups of patients, it's not appropriate. So in healthy women, in diabetics who are well controlled, in all this group, especially institutionalized patients, even in renal transplant patients, and prior to non-urological surgery, such as arthroplasties and cardiac surgery, it's really not appropriate to be treating asymptomatic bacteriuria. Okay,
So Lisa,
just
can I just ask you something? So I've got a number of patients who buy dipsticks and then they test their urine, and then they're asymptomatic, but then they look on the dipsticks and they say, so they say, oh no, I keep getting UTIs. And I said, but how do you know? And they say, it's on the dipsticks.
Yeah.
Yeah, it's quite difficult because they're really convinced that they're getting recurrent UTIs. But I mean, obviously it's quite difficult to manage these patients. So what are your thoughts on that?
Yeah. I mean, there are a lot of those patients that are getting recurrent UTIs, but I think one really needs to spend the time and explain the whole colonization theory to patients so that they understand that rather the devil you know than the devil you don't. So if you don't have symptoms, even if you culture a highly resistant organism, you should not treat it. If you have symptoms, then yes, treat it. But if you don't have symptoms, you just accept this is a friendly foe. It's sitting there, it's occupying a space and preventing the occupation of those spaces by more virulent organisms. So I think if they understand that, if you eradicate the guys living there, you make space for more resistant organisms, because you'll only get the ones left that have already been killed by the antibiotics. Also, it's very difficult to clear bugs that are living on mucosal surfaces. So, you then, by treating them, and you start chasing your tail. So I think I think most reasonable patients, if you explain it to them, they do get it. It is really problematic if you have patients who don't have a UTI, proven on culture, and have a dipstick that looks weird, and have other symptoms like that group of patients where they have persistent symptoms despite not growing bugs. So it is a difficult one, Steve, because you can also, if you look at how we culture, we're looking at minimum culture at 10,000 units, but you can get patients that actually have lower level of growth and actually are still infected. So it's quite a sword to walk on, to be honest. Yeah, so it's an uncomfortable place for us.
It's a bit like the biblical parable where Jesus goes into a cave and there's all these devils there. There's 5 devils, and he says he's not going to cure them, because otherwise, if he cures them, there'll be 10 devils come that are even more virulent than the first. Do you remember that story?
Parable,
yeah, that parable. So leave the
Don't believe.
devils there.
What Bible is that one?
It's the Christian Bible, New Testament, Matthew 15. But just check it out. So it's a difficult parable, but I quite get the analogy, because if they are asymptomatic, that's the point. They're asymptomatic. Leave them over there, because it's not uncommon to find them in older women, isn't it, Lisa?
Yeah,
Quite
it is.
commonly find
It is
older
an
women.
And in those patients, you know, especially the recurrent UTI ones, if you treat them, you actually do them a disservice, because then instead of getting a phosphomycin sensitive bug when they actually really have a bug, then they're going to get one of those carbapenemase producing multi-drug resistant organisms. So it really, you're not doing them any favors. So
No.
I would say it can be difficult, though, to be honest, because if you have the older patient, they may have other symptoms. They may have, you know, just some confusion or a bit of delirium, or so it can be a little bit more subtle. But you shouldn't be treating just because it's there. It's just going to end in tears, to be honest.
Okay, thank you.
So, I mean, and that's where one comes on to this topic, which is the recurrent UTI patient, and they are really the ones that make us pull our hair out, because they're really desperate women. It's a horrible existence to have this debilitating UTI on a regular basis. And so if one looks if you look at the various guidelines, the AUA, the EAU, the RCS, what most of them agree about is if you have more than 2 UTIs in 6 months, it's recurrent UTI, or more than 3 in a year. Some of the guidelines require only symptoms, but others say it must be a culture proven. So it sometimes is a problem when the patient says they have UTIs and then they actually don't have, they've got a dipstick diagnosis UTI, or they've actually not got even that, they've just got a symptomatic. So I think if they've got classic symptoms with a positive dipsticks, I think that even if they have not had a culture, you probably could still call them a recurrent UTI if it was otherwise a classic picture. So then in terms of this group of patients, you really do have to look for risk factors. You do have to consider non-antibiotic prevention. You can also give them antibiotic prophylaxis, but then the length comes into play. You have to also counsel the patient that if you're going to give them antibiotic prophylaxis, then if they get a UTI on their prophylaxis, they're more likely to have a resistant organism, and those may require hospitalization for intravenous treatment. I think it's also useful to give them this patient education we've spoken about, and also to institute some lifestyle measures. So once looking at investigation for patients with recurrent UTI, you should be culturing them at every episode, because they may just be getting a resistant organism and they're not responding because they're not getting appropriate antibiotics. If the patient is young with no risk factors, then they probably don't need an extensive workup, because you're unlikely to find something. The diagnostic yield is very, very low. I think it's very different if the patient has had extensive surgery before, if they might have an eroded tape, or if they've smoked for a long time, or anything like this. In those patients, you probably should be doing a cystoscopy, but as I said, in the general population without those extra risk factors, there's a low yield of findings. In terms of the ultrasound, it's probably worthwhile to do at least a post-MIC residual. I think that's one of the things I find most commonly in especially the older patient group that comes with recurrent UTIs, that they are carrying a larger residual, and that is something that you can mitigate, and you may be able to improve their risk for more infections in future. So
Lisa,
yes.
Sorry, on that, we've just had a question here. I'll come to Phil Zinn's question, and we'll just pull up Phil Zinn's question so we can get it out the way. Phil Zinn asks, if a woman has malodorous urine with E. coli with nitrite positives, is that a good enough reason to treat, or do you just ask her to put up with the malodor in the urine?
I think that probably is enough of a symptom, because most patients won't like that, and they generally will have something with it. I would probably, if they have that horrible odor, I would probably treat. But also, if they have that awful odor, those are the patients that often carry residuals. So they have that old stale kind of ammonia urine. I heard a story recently from a colleague where a patient walked into their consultation room with a travel size container of Handy Andy, and told the doctor, "This is how my urine smells." Just like this. So no, I think if they have that ammonia smell, there's definitely bugs there, and can't expect a patient to live with that. I would consider that enough symptoms to treat, to be honest.
Okay. Then there's another comment. It's not a question. It's a comment by Victor Olijobi. He he calls me Pastor Peter because he says that parable is absolutely right, Matthew 12. And if anybody wants to read Matthew 12, verse 43, there's that parable. There's another question.
Came quite close, eh? Matthew 15.
No,
Matthew
I said
15.
Matthew 12. You're calling me a liar. I'm a pastor. The other question, if a woman has repeated UTIs and increased resistance, often they go to urologists who do urethral dilatation. What is the sort of logic behind doing a urethral dilatation under these circumstances? You being a urologist.
There's no evidence for urethral dilations in this patient group. However,
Okay.
I tell you, patients will come and sit in my chair and swear to me that the doctor had my blaas pipie gereg, doctor, and then I was better afterwards. So there isn't evidence to support it, yet it's widely practiced, and there are some patients that will swear by it, and they'll actually come in with an agenda and say, you must go and do this again because the last time it was done, it worked. So I don't know. It's not something that I do routinely. Because there's not good evidence to support it. But as I said, some
I
patients
think there is a
believe
code for it, Lisa, or something, because I think they do
Yes,
both.
it
I
is.
don't know. It seems to
There
be
is a
part
code
of
for it.
the DNA of these
Urologists.
Yeah, no, there
cystoscopy
is a code for it. I think, was it 2069 or something like that? So there is a code for it. It doesn't pay very much. I think it pays like 150 Rand or something like that. It's not a very, it's not a, put it this way, it's not a code that's going to send your children to bishops on. Promise you.
Yeah, but if you do enough of them, it might, eh?
Yeah, listen, there's a lot of, that's a lot of dilatations you've got to do. You know, basically one of them is going to get you a burger and chips at McDonald's. And well, before that. So yeah, no, I mean, I don't do that. I think it's, if you're going to do a cystoscopy and the patient, obviously you can't get a scope in, then I think it's worthwhile. I mean, sometimes we see that in older patients that have got a bit of atrophy, but I think as a, you know, if you're scoping the patient, usually you're getting a 21 scope in anyway. So then I think it's a moot point, and they really don't need a dilation. Okay, so the next one. So this was a lady who presented to various colleagues for 2 years, and it does illustrate quite a pertinent point. So we ultrasound patients all the time that come in with recurrent UTIs, but some of the things can be quite subtle. And this is the same patient. So this ultrasound, you can see she's actually got a massive stone on the CT scan, but on the ultrasound, it's quite subtle because in an undilated system, you don't see stones very well because the stones are white and the fat in the venous sinus is white. The only difference is that stones have shadows. So you can actually see that there are shadows. I'm not sure you can see my pointer, and I don't know how to make the pointer work. But in the midsection of the kidney, you can see that there's these shadows behind these white areas, and those are stones. So, you know, it can be very subtle, and it's easily missed. And stones are not uncommon in the middle-aged population, especially in patients who have metabolic syndrome. So it is always something to think about, especially if the patient has persistent white blood cells and red blood cells in between the infections. Okay, so just when it comes to recurrent UTIs, I'm not sure gynecologists forget this, but urologists often forget to add vaginal estrogens. I do find that the cream works better because we sometimes see patients that are using Vagifem, and then when you actually look at the urethra, they've got this beautiful urethral caruncle. So I recommend that all of them use a little bit of cream on the around the urethra twice a week, even if they're using Vagifem. And there's really good evidence to support it. Doesn't work as well as antibiotics, but it does work well in in patients with recurrent UTIs. And I think any patient that has recurrent UTIs who's postmenopausal should and who can tolerate it needs to be on some vaginal estrogens. Then in terms of
Lisa,
the general, yes.
On that score, there's a new preparation, which is vaginal estrogen, that comes with a probiotic. Have you had any? Yeah, you put it in the vagina, lives in the fridge, and it's a preparation that allows a woman to have re-estrogenization plus recolonization of the vagina.
Yeah, I was going to talk about that because there is actually some evidence that supports the use of vaginal probiotics. So that old story where people used to put yogurt in their vaginas, we always thought that was an old wives' tale. There is actually some evidence now that, I mean, it's not yogurt that people are using now. They're using kind of more purpose-made probiotic vaginal pessaries and creams, but there is some evidence that supports the use of that. So, I mean, that sounds like a great product. I know that there was one of the compounding pharmacies that was making one that even has hyaluronic acid in as well. So I think that's definitely, especially for patients that don't want to take things orally. Specifically, there are some patients, I have a few that have had C. diff before, and they're really terrified to take any probiotics in case it affects their bowel flora, and some of them respond quite badly to those kind of things because they've got this gut permeability problem. So that's definitely a good to know thing. So in terms of lifestyle and non-antibiotic options, increased hydration. So there's some reasonable evidence that in premenopausal women who drink less than 1.5 liters a day, that if they increase their fluid intake to more than 1.5 liters a day, that you can reduce their incidence of UTIs. There is some evidence for cranberry extract, but this is coupled with fluid loading. How much effect the fluid has and how much effect the cranberry has, I'm not sure. D-mannose has some mixed evidence as well. There has been a recent RCT that's been a little bit conflicting, but I still use it. And then the evidence for probiotics is also quite mixed, and that is both oral and vaginal preparations. So people always ask me what they should use, and I kind of looked around a bit, and I think it's pretty much you need to use something that's got mixed strains of lactobacilli in, and there should be more than 1 billion colony forming units per dose. Just also remember with probiotics, if they're not in an enteric coated tablet, you probably should take them on an empty stomach so that you don't, not after a steak when you've got a whole bunch of acid around that's just going to eat most of those little guys up. And then I did speak a little bit previously about the plant-based compounds, which one can use not only in the acute setting, but also in the recurrent UTI setting.
Lisa, just before
Yes.
you leave this slide, or just go back to that slide, the next, yeah, that's it.
Oh, yes.
That's the slide. Fluid. How much? Now, we all know that you should drink 6 glasses of water a day, but that's rubbish, isn't it? Alan Ponton always said that's absolute rubbish. How much water should we drink a day just to stay healthy from a urological point of view?
Well, I don't think there is a good number in terms of what the data says. In UTIs, there's data for 1.5 liters. If you're less than 1.5 liters, you're in trouble. If you're more than 1.5 liters, you're fine. But obviously, if it's
a lot of water,
30,
1.5 liters. I mean, we don't live in the
It's 1.5 liters of
desert.
fluid. It's 1 liter. It's not water. It's fluid. So you
Fluid.
don't. It doesn't have to be. It doesn't have to be pure H2O. So you need a liter. I mean, that's what in the setting of recurrent UTIs, that is. So
Yeah.
obviously, if it's hot, then you need to drink more. But I mean, when one looks at it, it's basically the dilution is the solution to pollution. So I mean, when one's voiding more frequently, you are literally, it's a mechanical washing out that is assisting the control of the infection, because bugs are always, the urine is not sterile. It's just if you're flushing these guys out, I think their ability to attach and invade the bladder is less. So theoretically, I don't
because
have...
you remember Linda Cardozo, she used to say, she used to talk about the sippy Evian. She said if you walked around a bunch of shops, a shopping center, lots of people walking around with bottles of Evian in their hands, sipping away.
Yes.
And she said that's only necessary if you live in the Namib Desert. Then you can sip your Evian. Otherwise,
or if you're
water. Yeah.
Or if you're a renal stone former. I mean, if you have normal renal function, you can pretty much get rid of your solute load with probably between 500 and 500 mils in 1 liter of urine a day. I think if your renal function is not completely normal, then you probably do need a little bit more fluid. And obviously, if you're a stone former, we recommend stone formers need to drink over 2 liters of fluid every day. So, I mean, I think in terms of when one looks at recurrent UTIs, the evidence, but only in the premenopausal group, it's those who are less than 1.5 liters. If you can tell them to get them to drink more than 1, there is evidence that it will reduce the UTIs. But I don't think that
they empty their bladders every time and don't have walk around with a
that too. That too, yes.
Thank you.
Okay, so then there's a few other preventative measures. I think those of you who haven't heard of Euroimmune yet, I think it has become quite a great help in the recurrent UTI setting. It's not registered in South Africa, so you have to do a very irritating Section 21 application, but it's not too laborious. The company does help. It is a mucosal vaccine that you spray under the tongue at night, and it does have reasonable evidence that, and it does seem to help for the majority of patients. So some of the other things which we don't do often, I think it's an off-label indication here, is the use of gag layer replacement therapies. That's like cystostat that we use for painful bladder syndrome. It can also be used for recurrent UTIs. And then methanamine, which we don't have here. So some of the patients who go to the UK will often bring this back victoriously. We don't have it available here. Okay, so this is just a slide looking at Uramune. There's Alexa's email at the bottom. So as I said, it's a Section 21 application that they do. The company does help. It's either for 3 months or 6 months. You can see here in this figure A, there's placebo versus the 3 and the 6 months, and you can see that there is a definite decrease in the UTI episodes, and this effect seems to last up to about 12 months. So it really is a worthwhile. It costs about, altogether with the SAPRA application fee, which I think is now about 400 Rand, and with the cost that you got to pay the company, it's about 4,000 Rand. Insurance doesn't always pay, but if you think about how much Eurozone costs over 3 months, if you're getting UTIs, you eventually do cover the cost of the Uramune quite quickly, especially if it does work for a year. Okay, so and it has a strong recommendation in the guidelines as well. Yeah, we spoke a little about cystostat. If you are going to use it, you probably should consider giving a prophylactic antibiotic dose. And if you're going to use it, probably best to use a hydrophilic catheter, which isn't going to cause micro scratches and tears in the urethra, and just give them another UTI. So there is some limited evidence. It can be used, but it is really quite an expensive option. And I must be honest, I'd rather try Uramune before cystostat for patients with recurrent UTIs. I think it's different if they've got some UTIs and also painful bladder syndrome, but I think otherwise it is off-label. It is quite an expensive option, to be honest. Okay, then in terms of antibiotics, we've spoken about either continuous low-dose antibiotics, where they take something every day. And in my practice, that's either going to be macrodantin every night, or the other option that I often use is phosphomycin or Urozone, 1 sachet every 10 days. So if you think about it, for 3 months, that's 9 sachets. In those patients that have clear post-coital UTIs, if you give them continuous prophylaxis versus post-coital prophylaxis, there does not seem to be much difference between them. But if they're getting them randomly, then you can't use that. Then they have to go on continuous. If they don't like that idea, you can also just put them on a self-start program. So basically what that means is you give them a form, you give them a container, and say you give them a script for antibiotics. So they always have a course of antibiotics in their cupboard at home. So if the symptoms start, they immediately collect a sample, take the antibiotic after, and drop the sample off the next day or whenever they can at the lab, so that if they don't respond to that self-start, then you can change based on the resistance profile. So this is sometimes something which patients are, especially those that like to manage their care more actively, are more on board with, especially if they don't want to be on antibiotic for a prolonged period of time.
Lisa, just go back.
Yes.
That postcoital one, which
Yes.
one do you recommend? Because Catherine Matthews always to talk about Bactrim. Do you think that's satisfactory?
Yeah, I mean, the thing is, we had quite a high Bactrim resistance here. So one does really need to know what the prevalence of resistance in E. coli is within your population. And if it's higher than 20%, it's probably not something that you should be using, because it's probably not going to work.
Okay.
So one really does have to know. And it's easy enough to find out, can go at the local lab, or the guys at the local academic unit will often be able to tell you what that resistance kind of prevalence is.
That's a good idea.
I usually use macrodantin. I think Bactrim, because it's not used as much, has become a lot more useful. But it does depend on where you work, to be honest. So moving on to, yep. You done?
Yeah, thank you. I said thank you.
Yeah. So, I mean, the next is pyelonephritis, which would be the kind of the systemic infection where the patient has, obviously they've got fever, chills, nausea and vomiting, renal angle tenderness, and it may or may not follow a cystitis. And obviously we all know it's quite scary because of this risk of preterm labor. So in terms of investigations, if somebody presents in that setting, we usually will, I think this is, it doesn't have to be an admission, but if you think a patient has this, they probably should at the very least have an ultrasound. And in the very sick patients or those that have a stone history, we'll usually do a CT or a CT IVP as well. We also will image or upscale imaging to a CT IVP in patients who haven't responded to treatment in 48 to 72 hours, just because they can complicate with perinephric abscesses or normal renal abscesses. And these patients can be really, really ill. And I think they're probably most, if they're very big temperatures, will land up in hospital for a few days. In this group of patients, we do use fluoroquinolones a little bit more liberally. They are sicker, so one does really have to take that risk. They do penetrate the kidney very well because they're lipophilic drugs, so they do work very well, and you can often get away with a shorter course for pyelonephritis with a fluoroquinolone. Here specifically it mentions that you shouldn't be using the urinary antiseptics like nitrofurantoin or phosphomycin. So just something to remember, if you have a patient that is very systemically unwell, so once they're starting to get temperature, rigors, systemically very unwell, you shouldn't be using the urinary antiseptics because they just don't penetrate the actual renal parenchyma very well, and you're going to fail treatment in that patient. So one then has to give them the fluoroquinolone or the cephalosporin or something else. The urinary antiseptics are inappropriate once you have anything more than a simple cystitis. So the guidelines actually say that one should reserve ertapenem and only use it in patients where you've got proven sensitivity. But in most settings, this is now the treatment of choice in patients that have a hospital-acquired infection or patients that have recently been in hospital. If a patient has had a bad infection, you don't need to do routine clearance cultures because, as I said, if the patient is colonized but not ill, one shouldn't really be treating those patients because they can still carry those organisms and be well. So another group of patients, which is quite a headache, is the catheter-associated UTIs. And when we change catheters, we often use prophylaxis to prevent an infection related to changing the catheter, but you need to treat 17 patients. You need to cover 17 catheter changes to reduce one UTI. If you have a patient with an indwelling catheter that gets a UTI, there's always a question like, when do you change the catheter? And the guidelines state that when they get the UTI, you change the catheter and then you treat them. This is not the same for, so this is for bacterial UTIs. If the patient grows a yeast or a fungus, you need to change the catheter and reculture. And if the bug is still there after the change, then yes, you treat it. But I wouldn't treat on a single, if it's a yeast or fungal infection, I wouldn't treat on a single positive culture if they have a catheter. So, and then once again, to remind you not to treat asymptomatic bacteriuria. And if you have a patient that's doing clean intermittent catheterization, there is some evidence that kind of suggests that if you're using hydrophilic catheters, so those are the single-use hydrophilic catheters, that there's less of a UTI risk than if you're using a simple kind of Nelaton catheter.
Lisa,
Yes.
what is a hydrophilic catheter?
So there's a few companies that make them. I think Coloplast is one of the big ones. I think Teleflex has got a range as well. So they're basically single-use catheters that are laser cut, that come pre-lubricated with a special hydrophilic and coating. So when you touch them, they're incredibly slippery. So you don't have to use KY jelly or any one of those lubricants with them. So they come pre-lubricated. So when you look at a Nelaton catheter, for instance, it's got quite rough edges around the hole for urine drainage because it's just got a punched hole in it, and it's not hydrophilic at all. It's kind of you need to put a lubricant on it. So they don't slide in as well, and they do cause some micro tears within the urethral mucosa, which can actually allow entry of bugs. So that's why these hydrophilic catheters are recommended in patients with recurrent UTIs or high risk for UTI.
Thank you.
I suppose, wait, yeah, I can show you one.
A hydrophilic catheter.
Yes, yes, yes. So they come in, you're like, I don't know, can you see me?
I can.
So they usually come like in a container like this. And usually they have a little sticky thing that you can pull off like that, and it sticks against the wall. And then patients, when they're catheterized, they just open them like that. And then you see here's the catheters inside. And when you pull it out, it's already got the fluid and everything on it. Oh, sorry, I'm trying to show you. It's already got all the fluid on that, and they're very, very slippery and they're very, very smooth. So they, and then they just use them
Single
once
use
and
only, are they?
they're thrown. Sorry,
Single
use
use
only. Yes, yes, single
Wow.
use only. And for the right indication, the most insurances will pay for, I think, up to 5 catheters a day.
A day. Wow.
Yep. Okay, so we've been through that, and that. Okay, so I think one of the last things I wanted to speak about is something that we don't often think about, and those in the patients that repeatedly return with burning urine. Some of them may have a discharge, but often not. Pain around the meatus. Sometimes positive diptych, culture is negative. It is important to think obviously about a PID, but there are patients that carry these organisms in the urethra, so you can get a urethritis in women, and it is in some in the patients where you'd never culture an E. coli, but they really look like somebody that's infected. It is useful to go and look for things like chlamydia and mycoplasma and Neisseria gonorrhea, because they can get that and harbor that in the periurethral glands. So it is useful. You can either do a urethral swab or you can do the urine PCR, but I have been caught out by a few patients like this where they return all the time. They've been called a recurrent UTI, but we never really culture anything. And you then find that they have a chlamydia, you treat, and they're kind of miraculously cured, and they think that you're great. So it is important to think about these patients, and they're quite easy to solve once you know what you're treating.
And Lisa,
yes.
Do those chronic infections of the STDs, for example, the chlamydias, do they cause, as in men, do they cause urethral strictures? Because I used to, when I worked at Kruitskeer Hospital, they had a boogie clinic, and then the men used to come in for urethral dilatation with boogies. And that was the most upsetting clinic because they were next door to us. And it sounded like a torture chamber. Does that also happen in women?
So, in terms of women, I think when one looks, the strictures in women are exceedingly rare.
But why in women and why in men and not in women?
Well, I mean, they've got shorter and wider urethras. So, I think that's probably why.
But can't they stricture up like a man?
Well, I think the thing is, if you think about the periurethral glands in the bulbar urethra, and that's usually where one gets the fibrosis around the urethra. Many of those glands they drain just almost at the outside in female, in the distal third of the urethra. So you will often see that they will form a periurethral kind of a little cyst or collection, or they'll get they're a more superficial problem than in men, where it's in the bulbar urethra. So I think also women have just got wider urethras. So
right.
I'd assume, I don't have any evidence to support that. It's just that we don't see urethral strictures in women, even those that do get this. It's uncommon.
Okay.
I don't know why. I'm sure
so
there's a
dilating,
PhD in there
we
for
get
somebody.
back to dilating urethras. It's not going to do any good at all to a woman.
I mean, if a woman has a urethral stricture and they do occur, yes, then dilating somebody who has a urethral stricture and a bit of a residual volume, I think that's appropriate. But as I said, there's not evidence that I'm aware of that urethral dilations in a patient with no urethral stricture with recurrent UTIs and no residual that's going to make any dot of difference, So
thank you.
Okay, so just the take-home messages, they've kind of shown you this new classification, localized versus systematic. I don't think this has kind of been accepted widely. This is the new EAU 2025 proposed classification, which I think is just awesome because it really replicates what we do and what we deal with clinically. think important to kind of twig onto those patients that are most likely to run into trouble by looking at the risk factors, and it's really quite obvious who those patients are. I think we do sometimes forget about the patients, or the patients don't tell us when they come that they were in hospital, 2 or 3 months ago for a month because they had a heart attack or because they had an ankle fusion or whatever. So it is important to ask about the recent hospitalizations, which obviously will predispose them to more resistant infections. And then I think to, as a policy, limit fluoroquinolin and augmentin use, not to treat asymptomatic bacteriuria. And then I think one does in my practice, just because I see so many women with recurrent UTIs, I think I often do need to phone the ID physicians who share the room next door, for a little bit of help, because you sometimes do need to decide on what antibiotic is most appropriate in a patient with a very resistant bug. There is also something which I have found quite useful recently in patients where they're not too unwell but they are symptomatic and they have highly resistant organisms that are only sensitive to intravenous antibiotics. So there's this for Discovery insured patients, there's Discovery at Home, where they'll send a nurse to the patient's home and they'll get their intravenous antibiotics every day at home from the nurse. So I think in an ill patient, that's probably not the best thing, but in a patient that literally just has a antibiotic resistant bug with no oral agents available, that is very, very useful tool that I've used quite often in the last few months since it's become available. And if you work in a hospital where you've got one of those Discovery people, that helps. It really is quite a useful thing to have. And then I think one of the last things to think about is exploring the non-antibiotic prevention strategies, because they really do have some decent evidence to support their use. So yeah, and I think that's all I have for you.
That's wonderful, Lisa. I'm going to ask Steve to thank you. Just look at those 2 questions, Steve.
Yeah, let's
So let's finally knock them off.
Yeah, so Joe Robertson asks, if a patient is on macrodantin prophylaxis, should they continue when they start the Uramune?
So yeah, so that's one of the questions. So I usually will I'll usually overlap for a bit. One of the other questions that people often ask is, if I get a UTI when I'm on Uramune, must I stop the Uramune? And the recommendation is to just continue. So the one is I would generally overlap the two, and if they do get a UTI while on the Uramune, they must just continue with the Uramune.
Because I mean, Lisa, the Uramune's basically got 4 strains of bacteria in it, isn't it? So I mean, sometimes you're going to get a brand new from another bacteria that's not going to be covered by the. Then Phil Zinn is basically saying, thanks for a great talk. Is Candida a real cause for UTI or typically contamination from the vagina? If so, then what is an effective treatment?
Yeah, no, I think this is largely in the catheter associated UTI patients. So those are generally more ill patients where, and it's not only Candida, it's kind of, we've got Candida glabratus, and I've had one recently. It had the most exotic name that I've ever heard of it. It's kind of the names these guys come up with is awesome. But yeah, so that's not in a kind of a garden variety patient that on a urine you grow, that I would always make sure that that's not vaginal contamination. But that specific point was related to patients with indwelling catheters where you culture a bug, or it's not only indwelling catheters, if they've got any foreign body. So if they have a DJ stent for whatever reason, the urologist has put it there, those are the patients where the recommendation, if you culture a yeast on their urine, you must replace all of the plastic and reculture, and only if you get it on the reculture after replacing all of the kind of catheters or stents, then you can consider treating them for it.
Thank you, Lisa. Now I'm going to ask, we have unfortunately come to the end of our bandwidth, so I'm going to ask Steve to thank you very much indeed.
Yeah, thanks, Lisa. I mean, UTIs are obviously a very difficult thing to treat in many patients, and I mean, you've demystified a lot of it for us, reminded us about a lot of things that we heard about, and I think it's a tailored approach in the end. Often it's isn't one size fits all for everybody, and thanks for reminding us about the antibiotic options too, because sometimes the patient says Kaestner and Uricare and we roll our eyes, but In fact, sounds like they do work, and I mean, anecdotally, they do. And patients often say,
Yeah,
took a UTI and the infection got better, and there is some evidence for that now. So, I
No,
think that's
listen,
a good reminder.
I was also rolling my eyes about that Kaestner stuff until I kind of saw that it's actually now in the guidelines. It's
Yeah,
there.
Wonderful.
Lucky for them. So,
No, great talk,
yeah,
Lisa. People have said, lots of people have said, over 100 participants. So, Steve, that shows
no,
you.
it was. No, and it's an important subject. So, thanks, Lisa. Really appreciate it. And thanks to Pete, and of course, don't forget about Figo.
Figo.
Yeah.
Okay.
Yeah.
All right. See you all at
Yeah,
Figo,
don't
and
forget
see
to
you
go and
all
register if you haven't registered.
same time, same
yeah.
spot next
Yeah.
week, Steve. Thank you.
Yeah,
And
all right.
thanks, Lisa, once again, and to Chris. Thanks
Thank
very
you very
much
much.
indeed. And
Thank
to our
you.
sponsor.
Bye.
Bye bye.
Bye bye, Lisa.
Bye.
Bye.